Hi, can everybody see me and my screen?
Yes, ma'am, we can.
Varun?
Yes, ma'am, we can see you. Also,
Okay, so should we start?
yes, ma'am. Yes, ma'am.
Okay, good evening, everybody. This is Dr. Supriya. As Varun has already told you, I'm a obstetrician and gynecologist, and I'm associated with the Fortis La Femme in New Delhi. So thanks, Varun, so much for inviting me today to this lovely Geo masterclass of yours. And I hope that whatever we talk can make sense and can be a little insight into the topic that we're going to discuss today. So today's topic for discussion is uterine fibroids. Is it okay? Can I go ahead?
Yes, ma'am.
Varun?
Yes, ma'am. Please go.
Varun, should I continue?
Yes, ma'am. Please continue.
Okay. So as we said that the discussion topic today is uterine fibroids. They're also called myomas and they're also called leiomyomas. So I want to tell you that this is a very, very common condition and occurs very, very often in females. And just 1 second, let me just go on to the second slide. Uh, just a sec. Okay, so what are uterine fibroids? Now, just want to say that fibroids, I think everybody is aware of it, but I'm just going to elaborate a little. These are smooth muscle tumors which start from the musculature of the uterine lining. Here is the musculature of the uterine lining. You can see my screen. They start from here and they are very, very common in the reproductive age group. So, and this is so because they are supposed to be hormone dependent. That is why they are very common in the reproductive age group, so much so that we say that they are nearly about 70% of females by the age of 50 will have fibroids. Just that common. So they are smooth muscles, they are common in this age group, and the affects about 70 to 80% of women by the age of 50, most common in the age group of 30 to 50, because this is the time after menarche when the hormones start acting, the estrogen and the progesterones on the uterus, and they take that much time to grow. So they are very common in this age group of 30 to 50, but keep on increasing, and their incidence does increase to nearly 70% by the age of 50. It has been seen that there's an increased prevalence of these when there is a family history of fibroids. Like, suppose the mother has the fibroids, then very often the daughter will also have them. And the causes and the risk factors, as I said, the most important cause is, of course, the estrogen and the progesterones, which are acting during the reproductive age of one's life. Then there is a genetic predisposition. And another factor which increases the growth is the early menarche. Like if the periods have started earlier, means the uterus is getting more affected by the hormones. So there is more chances. These days, we are seeing very young girls in the age of 8 to 10 years who start their menarche. These people are much more prone to to have fibroids because of the increased constant attack by the hormones on the uterus. Then another factor which is being implicated in their etiology is obesity and lifestyle factors like diabetes and hypertension. Another factor which is very important is the ethnic background. These have a much higher prevalence among the ladies of the African descent. They are more common, they are more bigger, they are more severe in the Africans. And as I said, the age is mostly between 30 to 50 years of age. Now, what are the types of fibroids? Well, the types of fibroids, depending upon the way they are growing, they are distinguished or categorized into 4 degrees. They are called, the commonest is the intramural fibroids, because they start from the musculature of the uterus. When they start from here and they continue to grow here, they are called intramural. That is inside the myometrium of inside the musculature of the uterus. Now they start from here, but then they can start growing towards the outside of the uterus when they are called subserosal, or they can start growing towards the lining of the uterus when they are called submucosal. Very rarely, not very rarely, they sometimes develop a small stalk like a pedicle, and when that happens, then it is called a pedunculated fibroid. So these are the different types of fibroids depending upon the location. Now the size of these fibroids can vary from a small seedling to as much as a watermelon. What are the common symptoms associated with the fibroids? Depending upon the site of the fibroids, the symptoms differ. But commonly, the most common I definitely want to specify is that some ladies do not have any symptoms. They are asymptomatic, and the fibroids are just accidentally detected when they come for a examination for some other condition, or we're doing a pelvic examination, or they become pregnant. And the common symptoms which they can produce are: one is heavy menstrual bleeding. So this is one of the common symptoms. The patients have heavy bleeding, which can come in more frequently than a month. It can stay for longer, so the frequency can be more, or the intensity can be more, or the duration can be more. So heavy menstrual bleeding is generally caused by the fibroids which are in the musculature, like the intramural fibroids. Another thing that they can cause is the pelvic pain or the pressure. This especially occurs with fibroids which grow very big, and especially with subserosal fibroids. Because as the subserosal fibroids become big, they come out, grow from the uterus, and they come out from the pelvis into the abdomen. So once they come into the abdomen, or even while they are within the pelvis, they can cause pressure on various organs, internal organs of the abdomen. Like if they cause pressure on the urinary bladder, then the patient can have frequent urination. If they press at the back, if they are at the back of the uterus, like what we call the posterior wall, they can press on the rectum and they can cause constipation. Sometimes they just cause an enlarged abdomen because they become very big, sometimes, as I said, the size of a cricket ball. So these are the common symptoms. And also sometimes when they become big, they can cause pain during relationship. And another thing is that in a female who's trying to get pregnant, sometimes, depending on their location, they can cause infertility. They can cause difficulty in the conception. This is especially so with fibroids, which are growing inside towards the cavity, because as you all know, there's a small uterine cavity. And if the fibroid is occupying that space, then the pregnancy definitely cannot implant there. So they can cause infertility, and sometimes the patient is able to conceive, but then they can cause early miscarriages for the same reason that the space is already occupied by the fibroid. So the little embryo which has just got fertilized does not find place, and maybe there is an early pregnancy and then that gets aborted. So they can cause infertility, they can cause recurrent miscarriages. And as I said, many of them are just asymptomatic, not producing any symptoms, just lying there, accidentally detected when the patient comes for a routine checkup for another condition. So when do we advise that the patient should seek medical attention? Well, if the patient is having severe bleeding, heavy bleeding, intermenstrual bleeding is especially common with, again, submucosal fibroids, because this is the part of the uterus which is shedding and growing every month with the periods. What we call the endometrium grows, then it reaches a peak. If there is no pregnancy, then it sheds. This is the part which is causing the periods to happen every month. So if there's a fibroid there, it is going to interfere with the bleeding pattern. It can cause intermenstrual bleeding. They can disrupt daily life because of the heavy periods. The patient can be very uncomfortable. She can have anemia and all signs which are associated with a heavy menstrual bleeding, like anemia, breathlessness on walking, feeling malaise, feeling tired all the time. So this can happen because of the heavy bleeding that the fibroids cause. Then sometimes, as I said, that they can cause fertility concerns, and they can also cause persistent pelvic pain. So these are the common symptoms when patient has, they come and seek medical advice. And when we examine them, then we find that the fibroids are there. And so how do we diagnose these fibroids? Now these can be diagnosed by a simple pelvic examination. If we do a bimanual examination, we can sometimes feel them. If they are very small, they are not really felt, but if they are large in the interior and the posterior side, they can cause the uterus to become very big. They can cause an irregular enlargement of the uterus. So once we suspect that the patient has a fibroid, then we can ask for advanced investigative techniques. Like the first line that we normally do is the ultrasound. Once we do an ultrasound examination, we clearly see the fibroids here. You can see that this is the uterus here with the lining here, and this is the fibroid. They are very clearly seen because they are encapsulated and they have a very whorled appearance, and they cannot be missed on the fibroid. So once the fibroids are diagnosed and we want a detailed study about these, we can do the MRI or the detailed mapping for the magnetic resonance imaging can be done. And sometimes we can also diagnose them by doing a hysteroscopy and a laparoscopy. We don't resort to these methods as a first line because these are invasive techniques, but excuse me, if we are doing a hysteroscopy or a laparoscopy for another condition, then we can see them. Here we can see the fibroid here in the scope which has been put it through the cervix, which is called a stereoscope. You can very clearly see this tongue like projection projecting into the cavity. That's a fibroid as seen on the hysteroscope. And sometimes when we put in a laparoscope, we can see the fibroids lying sitting on the side outside of the uterus. So now let us talk about the treatments. What are the treatments that we need to do for the fibroids? First and foremost is the watchful waiting. If the patient is having no symptoms, we do not need any treatment. And sometimes if we diagnose them and we know that the patient has fibroids, we don't just let them be. We do want to follow up with them to see that they're not increasing in size. So watchful, expectant treatment, expectancy to just kind of see what is their growth pattern. Are they growing in size or are they static, and how they are going about. And then, secondly, we come to the active treatment. Now, active treatment can be a medical management. In the medical management, we talk about NSAIDs, which can be given for pain relief. NSAIDs like over-the-counter medicines like Advil, ibuprofen, Tylenol can be given. They decrease the pain as well as decrease the bleeding. Second form of medical treatment is the hormone treatments, which we give. Now, the hormonal treatment, which we give, are the oral contraceptives or the progestogens. Now, these kinds of hormonal treatments do not decrease the size of the fibroids, but they can prevent the heavy bleeding and they can prevent the pain. So we can just keep the symptoms under control, though they are not effective in effectively removing or decreasing their size. Now, the third treatment that we sometimes resort to is the gonadotropin releasing hormone analogs. These are hormones like the leupride and the gusarolin, which are sometimes given. They resemble the normal hormones which are there in the body, the releasing hormones like the luteinizing hormones. They are those analogs, so they go and combine with the receptors in the hypothalamus. And first, there is a little bit of an increase of the hormone, and then there is a decrease, because once they are constantly occupying the receptors, then the internal hormones cannot act on them. So they have an effect of decreasing the internal hormones of the estrogen and the progesterone. So with these analogs, we produce a state of kind of a pseudo menopause. We decrease the estrogen and the progesterone, and when we decrease the estrogen and the progesterone, then the fibroid size also decreases. So this is not a very definitive treatment because they do decrease the size, but they do have lots of other side effects. As we know that when we decrease the estrogen, the progesterone in a lady who's childbearing, after all, the hormones do have a lot of beneficial effects on the body, like they are protective towards the heart, they are protective towards the bones. Then, side effects like menopause, like hot flushes, breast pains, all those things can happen. So we don't give them for very long. They are given sometimes, like if the fibroid is very large and we have thought that we're going to do surgery for the fibroids, then to just decrease the size of the fibroid so that, the surgery becomes more easy and more amenable, we give the hormones for a short time. Another drug which can be used to decrease the bleeding is the tranexamic acid. This can be used for 3 to 4 days. This decreases the bleeding, decreases the pain. So this is all about the medical treatment. And now we also have some minimally invasive procedures. Initially, there was just the medical treatment and the surgery. But these days, we are also coming up with some minimally invasive procedures for the fibroids. And one important one is what is called the uterine fibroid embolization. In this, patients who are not really ready for surgeries or who have big fibroids and are having symptoms do not want to undergo surgery, or they have some contraindication for surgery, but they still want to preserve their uterus. For them, we can recommend this uterine fibroid embolization. In this, what we do is it's an OPD procedure. Patient doesn't have to be hospitalized. It's minimally invasive. We puncture the artery in the groin, just like we do stenting of the heart through the coronary vessels. In this, through the vessel in the groin, we puncture the vessel, we put in the catheter, and under fluoroscopy, that means we are seeing it on the television, on the monitor, we guide the catheter into the uterine artery and then into the vessel which is supplying the fibroid, and we inject small particles the size of sand. These are just PVA, polyvinyl alcohol particles, which are about 500 micron size, just the size of a small sand granule. We inject that into that cuts off the supply of the fibroids and it causes them to shrink. So the advantage of this is, as I said, a very small incision. There's no anesthesia required. Pregnancy is possible. Procedure takes less than an hour. Recovery is quick and safe. And it is deemed to be safe and effective for at least 10 to 20 years. Another thing which is coming out is the radiofrequency ablation and the MRI guided focused ultrasounds. Now, these are promising treatments, but yet more trials are needed before we actually implement them into the clinical use. And this, what we do is that again, under fluoroscopy or under ultrasound guidance, the interventional radiologist puts in a needle into the fibroid, and we pass in strong heat waves or ultrasound waves which cause the fibroid to kind of burn out and that size decreases. So these are promising treatments, but yet not fully there. We do need some more insight into these before we can actually start doing them on the patients. Now, the last treatment is the surgical management, which is actually the definitive treatment, but not the only treatment. Now, surgical treatment, we can categorize this into two degrees. One is the myomectomy, which is the preserving fertility treatment. And second is the hysterectomy, which is the definitive treatment. Now, the approach for these both can be, initially, it used to be an open surgery, but these days, very rarely open surgeries is done. There are some indications still, but very few. Mostly it is done either by laparoscopy, that is the pinhole surgery, or we can do it by hysteroscopy if there is a fibroid inside the cavity. Laparoscopy if they are more intramural or butting out like the subserous fibroids. And the thirdly and the last, the newest procedure these days is the robotic procedure, which is even less invasive than the laparoscopic procedure. Now let's talk about, we'll talk about the indications for the myomectomy, but let's also talk a little about the lifestyle modifications that the patient can do to help control their fibroid symptoms, or for them to not develop fibroids, or if they are there, not worsen their symptoms. First is exercise. Very, very important to remain within the body weight, because we say obesity is something which increases the incidence of fibroids, because obese tissue, fat tissue, produces more estrogens. Then these estrogens act on the uterus and they increase the size. So very important to have exercise, remain in weight control by proper exercise regime and diet control, and to have an anti-inflammatory diet, because it has been seen that diets which are rich in fibers, cereals, and fruits and vegetables, less of caffeine, less of alcohol, and no smoking, because all of these also interfere with the hormonal balance, and all these things increase the chances of having a fibroid. So if we follow a good anti-inflammatory diet, reduce our weight, we can manage our symptoms to some extent if they are not very severe. Another thing is stress management. This we can do either by yoga or by deep breathing techniques and meditation. Now, stress management helps because we know that stress increases the level of cortisol, and cortisol plays havoc with the hormones inside the body. So stress management is another important thing. And then, of course, tracking the menstrual cycle and heating pads for the cramps. These are the lifestyle modifications which we can recommend to the patients. and if they have symptoms which are not very, very severe. Now, let's talk a little about the fibroids in pregnancy. This is an important topic because very often we find fibroids in the pregnancy. It can be an accidental finding, or it can be a patient who had fibroids becomes pregnant. So they are common, very common, quite common, because the fibroids itself is a common entity. So they are commonly found in pregnancy. Sometimes the pregnancy just goes in uneventful, nothing happens. You can see here, there's a little baby inside the uterus and there is a fibroid along with. So sometimes there are no symptoms, no problems, the whole pregnancy goes absolutely smoothly, the patient delivers, but it can also lead to certain complications. So we need to be mindful, we need to be taking care of the fibroids, we need to monitor them continuously during pregnancy to see that they're not undergoing changes. So one thing is that I had already mentioned that they can cause infertility. Suppose the patient has got pregnant. Now what can happen if the patient does get pregnant with the fibroid? One is, as I already explained, that they can cause miscarriages. Then if the miscarriages doesn't happen and the patient goes on to further her pregnancy, they can cause pain. They can cause malpresentations. Malpresentation means that normally we have the baby's head down, the vertex down, because that is the part which is the most space, maximum space is there for the baby's head. Now, suppose there is a fibroid sitting there, the baby's head does not get a chance to fix there. So, the position can be either a transverse lie or it can be a breach. So, they can cause malpresentations. Then they can cause preterm labor. They can cause the pains to start earlier. Sometimes not only preterm labor, they can cause an incoordinate uterine action during labor, because the fibroids are there, the pain which has started, which is supposed to go nicely throughout the whole length and breadth of the uterus, doesn't go because the fibroid there is interfering with its passage. So they cause an incoordinate uterine action, so that increases the chance of cesarean section in the baby, especially if they are large and if they are occupying the lower part of the uterus. And by large, we normally mean that they are more than 5 centimeters, or they're more than about 10 or 11 centimeters. So monitoring is recommended during pregnancy, and management generally involves, if they have any problems which can occur. As I said, the pregnancy problems can occur. Sometimes the fibroids, especially in the early pregnancy, can also increase in size because there is more blood going to the uterus. So there's also more blood going to the fibroids, so they increase in size. But once they increase in size, they sometimes, because when they increase in size, the blood supply in the center becomes a little inhibited because the size has become more. So the fibroids can undergo degeneration, they can undergo infections, they can undergo necrosis. So all these things can cause an acute abdomen during pregnancy, causing the patient to have very severe pain along with nausea, vomiting, light fever. So management is generally hospitalization, and if possible, we manage by just putting the patient on rest, giving her adequate hydration, some intravenous antibiotics and painkillers. If they can be managed, then we do not want to do surgeries during pregnancy, because we want to avoid any surgeries during pregnancy because it can also harm the fetus. But sometimes surgery is needed for a fibroid which has gone totally haywire. So then we normally wait for the patient to, tide over the first 3 months, let her get into the second trimester, and then we can do a myomectomy, because that is the safest time to operate. Though it should be avoided at all costs, but if can't, then it needs to be operated. So now, what are the myths and what are the facts? There are common myths which surround the fibroids. So one of them is that fibroids always cause cancer. No. Now, the fact is that they are almost always benign. The chance of a cancerous change in the fibroid is very rare. And even when there is a fibroid cancer, which we call a leiomyosarcoma, it is mostly a fibroid which is developed as a cancer and not a cancerous change. But even if the cancerous change does occur, which is rare, it is to the tune of 0.01%. That is, less than 1 in 1,000 of the fibroids can undergo a malignant change. So, second myth is all fibroids need treatment. This is also a myth. The fact is, many don't. As I've explained to you, they are asymptomatic. They can remain so with just a follow up. And as they are estrogen and progesterone dependent, they are there during the childbearing phase. And as menopause sets in, the hormones decrease, and the small fibroids, less than 5 centimeters, very often shrink in size and do not cause any problems. The third myth is that hysterectomy is the only cure. No, definitely not. We have multiple methods. We have medical management, we have non invasive methods, and also some other non invasive, minimally invasive methods to deal with the fibroids. So, hysterectomy is not the only cure, though it is the definite cure is hysterectomy. But now let me tell you a little about the indications for myomectomy. Now, the indications for myomectomy are if the fibroid is very big, more than 8 to 10 centimeters, it is definitely going to cause in a patient who's planning to get pregnant, and it's better to be removed. Another indication for myomectomy is if there is a myoma growing inside the cavity, which is called a submucous fibroid, that needs to be definitely removed before the patient ventures into pregnancy, because they can cause difficulty in conception and they can cause miscarriages. Then another reason why we do remove only the fibroids, if the patient is young, she's just had one child and she wants to preserve her uterus for a future childbearing. We do not want to remove the uterus. So in a younger patient who still requires a uterus, and even if she doesn't require uterus, and if it can be sorted out, we can just remove the fibroids. So we have to tell the patient that myomectomy is a procedure which is removing the fibroids which are already present. But because the hormonal milieu is still the same, they can develop future fibroids. So if the patient still says, no, 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 definitely we do not want the uterus removed in a younger patient, we can do just a myomectomy. So once the patient has completed her childbearing and she is near her menopause age or over 40, 45, and she has multiple fibroids, then hysterectomy is the definite treatment. We just remove the whole of the uterus with the fibroids. And that is the definitive cure for the fibroids. So, what are the important key takeaways? Fibroids are common and usually benign. Treatment depends upon their symptoms, their size, locations, and the fertility goals. Multiple treatment options are there, medical and surgical and minimally invasive. So, take care of your body. It's the only place you have to live. Thank you so much.
Dr. Supriya, we have a few questions.
Yes, definitely.
Thanks for a wonderful presentation. We have a few questions.
Yeah,
Am I audible, ma'am? Yeah. So first
yeah,
question is from Dr. Ivan. Dr. Ivan is from Uganda. So
yeah.
the question is, how best can we differentiate it with molar pregnancy?
How best can we differentiate a fibroid with a molar pregnancy?
Yes, yes, that is the question.
Well, fibroids have a very typical world appearance on it's like a it's going round and round, and also that is what is PVC on the ultrasound. And in a molar pregnancy is generally all erratic cells lying together. Also, a hormonal test will help differentiate. In a molar pregnancy, the HCG goes just beyond what it normally shoots up during a pregnancy. In pregnancy, also the HCG levels are high, but in a molar pregnancy, they just go out of the window. And then when we do an ultrasound examination or an MRI, it definitely distinguishes between a fibroid and a molar pregnancy, because the fibroids have a very typical encapsulated appearance, round and whorled, and molar pregnancy is not at all definitive. It's not a whorled, it's not encapsulated. And along with the hormonal levels, we can differentiate between a molar pregnancy and a fibroid.
Doctor, we have another question from Dr. Kelly. He's from Ethiopia. So his
Yeah,
question is, often PID is associated with fever, vaginal discharge, and vaginismus.
yeah,
Also, those with PID often have specific risk factors like intrauterine instrumentation, recent surgery, aseptic abortion, and risky sexual behavior.
yeah.
Dr. Caleb, what is the question here? Can you help us? The message looks incomplete. Hello, Dr. Caleb, can you unmute yourself and ask the doctor directly? Or can you specify? Uh, what exactly the question is. Meanwhile, ma'am, we move to a question from Dr. Chucks. Dr. Chucks is practicing in Nigeria. So,
Yeah.
how long after myomectomy should a desirable mother expect to conceive?
Well, after a myomectomy, because we have put an incision into the uterus, we normally want, just like if a patient has had a previous cesarean, we advise them not to have another baby for 2 years so that the uterine scar is nicely healed. Similarly, after myomectomy, if it has been a laparoscopic myomectomy done for a subserous pedunculated fibroid where the myometrium has not been opened, they can have a pregnancy after they become okay, maybe after about 6 months. But if the myometrium has been opened to remove the myoma, then we normally advise that the patient should not get pregnant for at least 1.5 to 2 years.
Okay. Dr. Chucks, sorry for the network issue at your end. Uh, but yes, Dr. Supriya just answered your question around myectomy. Safe to have pregnancy, planned pregnancy after it has healed and generally 6 months break. And there's a follow-up question from Dr. Chucks. How do we differentiate the uh, dyspareunia second to uterine myoma and that of PID?
Okay, so the dyspareunia, which is there with the PID, is always normally associated with vaginismus, vaginal discharge, which can be foul smelling, and they may be associated urinary tract symptoms. But normally with the fibroid, the dyspareunia is not associated with all these symptoms. And then once we can pick up a discharge by a vaginal speculum and just send it for the examination. In PID and all, we will find the infective organism. In fibroids, it's usually not there.
Dr. Supriya, we have another question from Dr. Innocent Zili. He is Dr. Innocent Zili. He is practicing in Kenya. So, hi,
Yeah.
Dr. Supriya, great presentation. What are the benefits of GnRH analogs?
Well, as I explained before in my presentation, we are using the analogs sometimes to decrease the size of the fibroid. So one indication is, just a second, excuse me. So one of the indications for this is, suppose the fibroid is very big and we have planned to remove it by myomectomy. We want to decrease the size of the fibroid before the surgery, because bigger the fibroid, we expect more bleeding to happen during surgery, and we do not want that. So we decrease the size by giving these gonadotrophin releasing hormone analogs for maybe maybe about 3 months. We can give a monthly dose or we can give a 3 monthly dose. That decreases the size of the fibroid and becomes so that it becomes easier to take it out at the time of surgery. And another indication for this is if the patient is perimenopausal. We know that. Sorry, I think there is a little disturbance.
So
Can you
sorry,
hear
ma'am.
me?
Yes, ma'am, we can hear
Okay,
you.
so the second indication for these is when the patient is in the perimenopausal age group, and we know that once the menopause sets in, the fibroid is going to shrink in size. So, to just kind of hasten that process up, and anyway, she's entering menopause, her hormones are anywhere decreasing, we can give those hormones so that the fibroid shrinks quicker and she doesn't have a late menopause, because sometimes fibroids are known to delay menopause. So that delay doesn't happen, we can give those hormones for a few months.
Okay, ma'am, there is another question. There is a question from Dr. EPA. Dr. EPA is from DRC. Soumya, you may have to take notes and give the response in French. So, first-timer mother who has undergone a myectomy and is now pregnant, what delivery method should be chosen?
Normally, if the cavity has been opened, we would like to do an elective cesarean section. If it is just the subserous fibroid which has been removed, the uterus has really not been touched, because when we are removing the subserous fibroids, sometimes they have a little stalk. We just kind of clamp it, so we have not really interfered in the uterine musculature. Patient can have a normal delivery, but it has to be an institutional delivery. It cannot be a home delivery, because sometimes complications happen during pregnancy, and if they happen, I mean, during labor, and if they do, then immediately the patient can be taken over for a cesarean. So definitely an institutional delivery and under proper surveillance.
Okay. Samya, you will translate this into French and share with Dr. EPA. Now, ma'am, we have another question from Dr. Chucks from Nigeria. He didn't get the medical management of fibroid part, especially the part around hormonal therapy and its example.
Okay. So the hormonal therapy, which we normally give, is we can give combined oral contraceptive pills. What they do is they create a state where the internal hormones decrease. So once we are decreasing the internal production of estrogen and progesterone, we can decrease the bleeding caused by the hormone, caused by the fibroid. So they are not totally effective in removing the fibroids, but they can decrease the bleeding, and they can also cause the patient to have painless cycles.
Okay.
So that is the estrogen and the progesterone which can be given, or sometimes we can give only the progesterone. And these days, a newer IUCD has come in, which is called Mirana, which releases a very tiny amount of progesterone every day. This is put inside the uterus. It is a IUCD, an intrauterine contraceptive device. It releases a small amount of hormone every day, and this hormone is progesterone, which is opposite to the effect of estrogen. Estrogen is the hormone which is mostly implicated in the growth of the fibroids. So when we give the progesterone, the effect of estrogen is countered, and so we can help manage the pain. We can help manage the cycles become there's no bleeding, or there's very scanty bleeding happening, and so and the internal hormones, with a continuous flow of progesterone coming into the uterus, the internal hormones decrease, and that is what decreases the size of the fibroid.
Okay, Dr. Supriya, perhaps you will have to recap the indication surgery part, because this is another question from Dr. Chuck, because I think he had network issue in between. So hence
Okay,
the
so the
request
surgery part, as we discussed, is there are two surgeries, right? The one is the myomectomies, which is just the removal of the fibroid, leaving the uterus intact, and the second is the definitive treatment, which is the hysterectomy. So myomectomy has its own indications, like if the patient wants to preserve the uterus, or the patient is very young, she wants to have her childbearing, and she does not want to do away with the uterus, then only we do a myomectomy. So it is either a fertility enhancing procedure, or if the patient is young, she's just had one child, she wants to have a future, or if she's allowed 30, 35, and she doesn't want to have her uterus removed, we can remove the only the fibroid, which is the myomectomy. But explaining the patient at the same time that myomectomy is a procedure which is only taking out all the fibroids which can be seen. There may be other seedling fibroids which are going to grow in size, or there may be new ones which can develop, because the hormonal milieu is still the same and is going to remain the same till the patient gets into menopause. So this is the myomectomy, which is the fertility preserving surgery. And then the definitive treatment is hysterectomy, which is done in a patient who has had her childbearing, or who has very big fibroids, and or doesn't want children, and she is more than 40, and she says, I do not want to be subjected to heavy bleeding and taking medications all the time, and she's done with her with childbearing, then we can remove the whole uterus with the fibroids, and that is the definitive treatment for fibroids.
Okay. Ma'am, there is a very interesting question, actually two questions from Dr. Dima. Dr. Dima is from Ghana. So his first question is, at what stage should the heteroscopy be deployed instead of MRI?
Excuse me, what did you say? Can I get the question repeated? In what
At
stage?
what stage should heteroscopy be deployed instead of MRI?
Hysteroscopy.
Yes, yes, ma'am.
As opposed to MRI. See, there are two
Yeah.
different modalities. MRI is a investigative radiological procedure. It doesn't have any side effects, because there are no radiation. It's a magnetic resonance imaging. The patient is just put on the table, and it takes very thin slices of the tissues, soft tissues, and gives you a detailed view of the fibroid. So this is an investigative radiological procedure, whereas hysteroscopy is a minimally invasive, though invasive, endoscopic procedure, in which we put in the scope through the cervix. There are no incisions given. We put in the scope, and under vision, we see the uterine cavity, and if we see that there is any fibroid or a fibroid polyp, we can remove it. So there are two different procedures totally. One is non-invasive and one is invasive, requiring hospitalization.
So, ma'am, how does the doctor decide which one to deploy? Like, are there any
No, we
indications
do
or
not.
something?
We do not deploy hysteroscopies for diagnosis of a fibroid. Fibroids can be diagnosed by clinical examination. They can be then, definitely diagnosis can be reached by fibroids. And then only if there is a doubt on the ultrasound, fibroids will be definitely diagnosed on ultrasound. If there is some doubt on the ultrasound that may be that 0.0%, 0.01% chance that there may be a cancerous growth in the fibroid, we advise the patient to have MRI, because that gives us a detailed image of, very thin slices of the fibroids, tells us about it. And then we can also see associated conditions, like normally when there is a cancers are there are lymph nodes there present, there is ascites present, there may be minimal fluid vision which can be seen on the MRI, which is sometimes missed on the ultrasound. So hysteroscopy is never employed as an investigative tool. It is employed as a tool which we can put it in and we see it and we treat it at the same time. It's more of a treatment modality.
Okay. And Dr. Dima's next question is, ma'am, around nutrition. He wants to know your perspective on meat consumption as against planetary health diet in managing uterine fibroids.
Nutrition, very important to have a you to be remain within your BMI. Weight control, very important, because it's more important in obese patients. So exercise and diet control. An anti-inflammatory diet is especially recommended, and that is generally the Mediterranean diet with lots of green leafy vegetables. Then things which are good in the omega-3, like the walnuts, the flax seeds, the olive oil, olives, and also no caffeine, no alcohol.
Okay.
No smoking, very, very important. No smoking is more implicated in the increase in the size and the complications associated with fibroids than any other condition.
Okay. And ma'am, what around, is it possible, like, any indicator around meat consumption, like red meat or
Yes, we say
lean
less of
meat
red
or
meat.
fish?
Yes, in
Less of red meat.
red meat is supposed to be an inflammatory diet. So we normally recommend white meat, which is fish and turkey and chicken.
Okay. Okay. Soumya, there are few French questions. Can you translate them? Soumya, can you translate the French questions so that I can read it out to Supriya, ma'am? Okay. Ma'am, we have a few more questions from Dr.
Yeah.
Isaya.
Yeah.
Dr. Isaya is practicing in Tanzania. Meanwhile, there are a couple of questions in French also. Soumya will translate them. Okay, ma'am. First, thank you so much for the nice presentation. And he was a little late. His apologies for that.
No, no,
So,
no problems.
okay, I think you covered this. The question is, what is the food to offer anti-inflammatory in to counteract fibroid? I think you just covered it.
Yeah.
And how effective is focus ultrasound waves in treating fibroids compared to available modalities?
See, the focused ultrasound waves is what we call the radiofrequency ablation. They are being tried, there are clinical trials going on, but yet there is not very definitive proof, but it is a hopeful treatment in the future, a non-invasive or a minimally invasive procedure for dealing with fibroids. Right now, we basically have the minimally invasive procedure, which is happening is the uterine artery embolization. But this radiofrequency ablation and MRI ablation are still undergoing clinical trials.
So, ma'am, there is still time before we can
Yes, before
definitively
we
conclude on this.
definitely start using it on our patients.
Okay. So, ma'am, there is question from Dr. EPA. Dr. EPA is from Kinshasa, DRC. Is what is the treatment of hypermenorrhea in a virgin woman?
I understand hypermenorrhea. What does he mean?
Ma'am, actually, we translated it from French to English, so there could be
Treatment for what did he say?
for an unmarried woman, treatment of
Dysmenorrhea. It should be
hypermenorrhea.
dysmenorrhea, I think.
Dysmenorrhea. Okay, okay. Yeah, ma'am,
Uh,
that's the
dys,
limitation. I think French.
yeah,
Yeah,
yeah. Don't
dysmenorrhea.
worry about it. It's dysmenorrhea or amenorrhea.
Ma'am, in French, the word that he has written is L hypermenorrhea. So it could be, ma'am, if you can answer for both dysmenorrhea and
Okay.
amenorrhea.
So what was the question? How do we deal with the amenorrhea in
Yeah,
a?
yeah, yeah, yeah. In a unmarried woman.
I think it will not be amenorrhea, because amenorrhea means no menstrual bleeding. It is most probably dysmenorrhea, which is painful periods.
Okay, yeah, okay,
So, in an unmarried female, as I said, first we need to definitely rule out that there is no fibroid, there are no adenomyosis or endometriosis or a PID which is causing the problem. If we have the problem in front of us, we are able to treat it much better. But basically, for dysmenorrhea, the medical treatment is either NSAIDs, over the counter pain medications like Tylenol, ibuprofen, naproxen, Advil. These can be given. And if the dysmenorrhea is very severe and the patient is okay, we can also give her a trial of oral contraceptives, because these pills also decrease the pain during the periods and also decrease the flow. So they cause the periods become regular, scanty, and pain free.
okay. Dr. Boris, can you translate this in French for benefit of Dr. EPA? Dr. Boris, I think you speak both languages. Is it possible for you to translate this?
Can you type the word in the chat group, please?
Is it okay? So I think Soumya has taken notes. She will type and we will share it with you and Dr. EP later. So now,
Okay.
okay. So now there's question from Dr. Ivan, Dr. Ivan from Uganda. So he wanted to compare uterine fibroid embolization and myomectomy.
See, as I've, I think, discussed before also, the
Mhm.
myomectomy is a surgical procedure which needs hospitalization. It's more invasive. Uterine artery embolization is an OPT procedure done by an interventional radiologist. Myomectomy is done by a gynecologist. Myomectomy can be done either by opening the abdomen, which is called a laparotomy. It can be done laparoscopically or it can be done robotically. And the uterine artery embolization is done by an interventional radiologist along with the gynecologist, who puts in a catheter through the groin artery, takes it into the uterine artery, and injects small particles, which are mostly polyvinyl alcohol, small sand sized particles. They inject it into the uterine artery or into the vessel which is actually feeding the fibroid, so that the blood supply gets cut off and the fibroid sizes decreases over time. So it is less invasive, it's an OPD procedure, and definitely better than undergoing a myomectomy.
Okay. Ma'am, we have next
But
question
it is not,
from.
it has got its limitations. You cannot do it for all kinds of fibroids. Fibroids which are very big, which can have some cancers. If there is an infection, a uterine infection or some, the uterine artery embolization is not indicated. There are contraindications.
Okay. Dr. Supriya, next comment we have from Dr. Robzak from Nigeria. Thanks for the presentation. And again, his apologies for joining a little late. And he learned a lot from you. So now he has multiple questions, ma'am, three questions. The
Okay.
first is, how do you know the exact location of fibroid on the uterus? Because he joined late, perhaps he missed that part, ma'am. If you can cover that again.
How do you know the exact location? We can do a biomanual examination and we can feel the irregular enlargement of the uterus, which can be there interiorly. When we know it's an interior one, it can be posterior or it can be on the sides. And then definitely to diagnose it, then we normally ask for an ultrasound, which gives us the exact location.
Okay. Although you covered it, ma'am, the next question is hysterectomy a best option for women that have completed their family size? Yes, Dr. Robzak, that is the best option uh, for female who have completed their family size. And his follow-up question was, if yes, are there any side effects post hysterectomy? Ma'am, this part you have to cover.
Yeah, so yes, definitely it is a patient who has completed her childbearing and is over 40. For her to not suffer more the effects of the fibroid, hysterectomy is a very good option. And if the hysterectomy, see, normally we do, if the hysterectomy is done only for the fibroids, and we are sometimes, if we are doing a hysterectomy on a patient who is less than 50 years, we normally leave the ovaries behind if they are healthy. And if we are operating on a patient who's more than 50, we normally want to remove the ovaries as well. Well, if the ovaries have been left inside, then there is no surgical menopause. But if the ovaries have been removed in a younger patient, because once we went inside and we saw that they were not healthy, it's not worth it to leave them inside, because that means today we are removing we're doing a surgery for removal of the uterus. Maybe a year or two later, she has an ovarian cyst or an ovarian tumor, and we have to do another surgery. So if the ovaries are not looking healthy, we want to remove them. And if they're removed like before the normal age of menopause, which is 48 to 52, then we should give some amount of hormone replacement therapy till the patient goes into the normal age of menopause, so that she
Okay.
doesn't have a very dramatic surgical menopause.
Okay.
Because the side
We
effects of the menopause, if it is done surgically, is much more severer than what happens naturally. Like there are, the patient can have very bad mood swings, hot flushes, breast pain, depressions, anxiety, palpitations. All these things can happen. So to prevent all those, we like to give HRT, but these days we do not recommend HRT to very long. And but we like to give it till the age of a normal menopause, which will be about 50 to 53.
Okay. Another question from Dr. Isaya. So, is there any possibility to have targeted gene therapies that can be applied to treat fibroids? Whether, okay, there are two questions, ma'am. The first about
Okay, the
therapies,
first
please.
question, the answer is yes, it is genetically predisposition is there, but yet there are no definitive targeted gene therapies for fibroids, because we actually don't even really know what is the definitive cause. We assume, yes, it is estrogen and progesterone because we know that they shrink after menopause. So targeted gene therapy will be there, but not right now, maybe in the coming future.
And now here's another question is whether blocking the hormones that stimulate fibroid growth, how do you view the future of, how do you view this future? Um,
That's no problem. The we are blocking the internal hormones by even the pills. These days girls are taking oral contraceptive pills from the age of 17 till 35. As long as there are no contraindications, there is no problem. The patient has to be a non-smoker. There should be no family history of strokes or hypertension. It's quite safe.
okay, Dr. Supriya, the French doctor provided clarification. Yeah, your guess was correct about that unmarried woman,
It was
female.
dysmenorrhea.
Yeah, it was dysmenorrhea, prolonged
Yeah.
heavy
So I've
bleeding.
dealt with it. Yeah.
Yeah, yeah. And now there's question from Dr. Kingsley. Dr. Kingsley is from Nigeria. Does Mirena treat fibroid?
Mirena also, as I said, it's an intrauterine contraceptive device which is releasing very small amounts of hormones. So it doesn't treat fibroids, but helps control the symptoms of fibroid.
Okay. Now, there's
Treatment is
question.
only definitive is either removal by myomectomy, hysterectomy, or minimally invasive procedures.
So there's question from Dr. Innocent, Dr. Innocent from Kenya. When do we use Premolune N in uterine fibroids?
Primarily 10.
Yeah,
It
Premolene.
is just one of the progesterones which can be given, just like Mirena. We can give Primolet N also to the patient. But better is to give a combination. But sometimes when the patients cannot tolerate the estrogen progesterone combination, we can give Primolet N. We can start with a BD dose starting from day 5 till day 25 of the period, or we can even give it continuously. If the patient is not keen to have her periods, you can give it continuously. If the patient wants a withdrawal bleeding, you can give it from the 5th to the 25th day. Stop it, the patient will have a bleed which will be much less than a normal bleed. It will be much more scantier and it will be pain free.
Okay. Ma'am, this is Dr. Ivan's question again about the relapse. I think you answered around myectomy and hysterectomy. So in case of myectomy, is there a chance of relapse?
Myomectomy, yes, because we only remove the fibroid which we have seen. There may be small seedling fibroids which are going to grow in size. There can be new fibroids which can develop. So there is definitely a chance of relapse because the hormonal milieu of the body is the same. The patient is still producing estrogens. She's not gone into menopause. She's still got the hormones going on. So they can occur again.
Okay. And now there is a first compliment from Dr. Ivan ma'am for a beautiful presentation. She absolutely loved it.
Thank
And
you
it
so
is
much.
his
It's been a
request.
pleasure.
It is his request already for that when are we organizing another session with you, ma'am, on another topic.
Okay, that'll be great. Absolutely. I look forward to it. Definitely. We will tie up with Varun and we'll get back to you very, very soon.
Can she move?
Okay.
Can she walk?
Yeah, she's smoking, she's moving, but she's
And and we have another question, ma'am. Okay, so this question is from Dr. Robert. Okay, again, there's another question from Dr. Robchak from Nigeria. His question is there any way to prevent recurrence in a woman that had myomectomy and is not able to get pregnant post-myectomy for a long time? Ma'am, yes,
Uh,
this question should be dealt with, ma'am. The woman got myectomy done because she wants to have a
a
child in
baby.
future,
Hmm.
and there are issues, so the fibroids may reoccur. Then, ma'am, please deal with this topic. Like, how do we plan the chances of
See, if
pregnancy?
the patient has had a myomectomy and she's trying to get pregnant and she doesn't get pregnant, then we have other procedures to do it. I mean, why to wait? We don't want to keep on waiting. We can go in for the test tube baby and IVF.
Okay. And, ma'am, there is no way to prevent recurrence, right? You
No,
just
see, if
covered
the
that.
patient is still in her childbearing phase, you cannot prevent recurrence because, as I explained to you, it's the hormonal milieu which is the same. It is going to
Okay.
remain. We have not changed that.
Okay.
We have only removed what it has caused, and we have only removed what we can see. There are other seedlings, sometimes they are so small you can't even see them. And you've done your surgery, and those seedling ones are now going to grow big.
Okay. And now there is a question from Dr. Robert Latio. I mean, his apology for joining late. And he would like to know how protected is the pregnancy in fibroids. Ma'am, you covered it in the risk.
Yes, I've covered it fully.
Yeah, but ma'am, it would be great if you can
Okay,
do a
all
little
right.
recap.
Okay, all right, all right. You're
Yeah.
really testing my throat, but I'll go ahead and do it.
Ma'am,
See,
Delhi Air is testing your throat.
no, no, no. I'm very much indoors.
Okay, okay.
All right. So the thing is that in pregnancy, the fibroids in pregnancy, see, sometimes they interfere. They do not cause you to get pregnant, right? They can cause infertility. And as I explained, especially the ones which are very big or they are butting into the cavity, the submucous fibroids, they will prevent a pregnancy. So they can cause infertility. Or they can cause, if the patient gets pregnant, they can cause early miscarriages. And now, if the patient has got pregnant and she is continuing with the pregnancy, then what are the things which can happen? Is that what you want me to tell?
Yes, ma'am.
Okay, so we normally want to follow up a patient who's pregnant with myomas because sometimes it can be totally asymptomatic. The pregnancy can just progress uneventfully like a normal pregnancy, but sometimes the patients can have problems like they can cause pain, they can increase, the fibroids can increase in size, they can undergo degeneration, they can cause malpresentations, they can cause early premature labor, they can cause an incoordinate uterine action, leading the patient to have an increased incidence of cesarean sections. They can cause postpartum hemorrhage. So all these things can happen in a pregnancy with fibroid. So it's a high risk pregnancy which should be monitored closely.
Okay. And ma'am, is there, I think here's a follow-up question. Does the period of pregnancy, like, does it control the fibroid growth? Like, if the woman gets pregnant,
See,
would it
normally
suppress
they
it?
say that in the first 3 months, at the first trimester, the fibroids can grow in size because there's more blood supply going to the uterus. So that is also increasing the blood supply of the fibroids. So they increase in size. But once they've increased in size, they don't really increase too much more in the second and third. And after pregnancy, they again shrink back. They shrink back to their original size.
Okay. Okay. So I think, ma'am, we are almost reaching the end time of the session. If
Yes.
anybody has any more questions, you can ask now, or you can share your questions in your work group. We will, Jivo team, Soumya or I will share it with Dr. Supriya, and we'll get you the response. Dr. Supriya, with your permission, we may conclude the session.
Yes,
And
absolutely, absolutely. So I'm just stopping my sharing and I just want to thank you all for a patient hearing. And it's been a nice, hopefully, a nice interactive session.
no, ma'am, how it was for you? Like all the many doctors are complimenting you. They want a repeat session. I'll
Yeah.
request you to provide your
I'm happy for
availability
that,
for
Varun.
I'll request you for a availability for a repeat session. And thanks a lot, ma'am. Thanks a
All
lot for
right,
joining us
Varun.
today.
Okay,
And
so once you're back in Delhi, then we will definitely meet up.
sure, ma'am. Sure.
Okay.
And thank you everyone for joining us on a Sunday. And if you have any patient case, like any complications to discuss, you please don't worry about whether you have to make referral to India. You can discuss your doctor's notes. We'll share it with Dr. Supriya. Dr. Supriya will accordingly guide whether they need to visit Delhi or not. And ma'am, there is a request from Dr. Isaiah also that please come again. And then Dr. Robzak, ma'am, I'll be after your life to give your availability for a follow-up
Okay,
session,
sure,
ma'am, in
sure,
the
sure.
coming few weeks. Thanks a lot.
Definitely. All
Thanks a
right.
lot,
Okay,
everyone.
bye-bye, everybody, and good night from me. Bye.
Yeah. Thank you, ma'am.
Bye.